Welcome back to the deep dive. Today, we're really getting into the weeds, tackling a set of sources on something incredibly complex and high stakes, congenital heart defects.
Specifically the ones showing up right at birth in neonates.
Exactly. And our goal here isn't just, listing them off. We want to give you, the listener, a kind of fast track to understanding the hemodynamics, the sounds, those murmurs, and crucially, the urgent steps needed to save these tiny lives.
It really is all about time, isn't it? And I think to really get this, we have to go beyond just memorizing facts. We need to understand the physics, the huge circulatory changes that happen the instant that baby takes its first breath.
Right.
That shift, that's the engine driving everything, whether blood goes left to right, causing volume issues, or right to left, leading to those immediate cyanotic crises.
Okay, let's unpack that foundational switch. Because for 9 months, it's a totally different world inside, circulation-wise. What has to change, and why does that set the stage for all these problems we're about to discuss?
Well, in utero, the lungs aren't really doing the breathing job yet. They're fluid-filled, constricted, right? So pulmonary vascular resistance, the PVR, is super high.
Okay.
And pressures are pretty much equal everywhere. Blood mostly bypasses the lungs through the PFO, the foramen oval, and the PDA, the ductus arteriosus.
The fetal shunts.
Exactly. Then birth happens. Cord clamped, first breath. Bam. Two things happen instantly. Oxygen hits the lungs, PVR plummets as those lung vessels relax.
Okay, massive drop.
Massive drop. And simultaneously, the placenta's out of the circuit, so systemic vascular resistance, SVR, shoots way up.
Ah, okay. So we flip from this sort of low resistance, equal pressure fetal system to one where the left side is suddenly the powerhouse, pumping against high systemic resistance, and the right side is pumping into this new low resistance lung circuit.
You got it. And that new pressure difference, left side higher than the right, that's the whole game.
Yeah.
If there's a connection where there shouldn't be, high pressure pushes blood to the low pressure side, left to right.
Leading to the acyanotic defects, volume overload.
Precisely. Too much blood flooding the lungs. But if there's a major blockage on the right side, the pressure can actually build up there, reverse the flow, and push deoxygenated blood right to left into the systemic circulation.
And that's cyanosis, immediate blue baby.
That's the crisis.
Okay, let's dive into those acyanotic classics first. The L to R shunts. Too much volume, too much flow to the lungs, leading eventually to heart failure. And we have to start with the most common one, right? The VSD.
Ventricular septal defect, absolutely. It's just an opening in the wall between the ventricles. Now, right after birth, the shunt might be small or not even there yet because that PVR hasn't fully dropped.
Still some resistance in the lungs.
Yeah, exactly. But over the first, say, few weeks, as PVR keeps falling and the left ventricle's higher pressure really takes over, that L to R shunt gets going.
Yeah.
And it's purely a volume issue.
Okay, walk us through that, the hemodynamics.
Yeah.
How does that volume overload make a baby with a big VSD so sick? Why heart failure?
Think of it like a flood building up. The left ventricle pumps blood out to the body, but a big chunk, sometimes even more than half, with a large VSD, takes the shortcut across the whole into the right ventricle.
Okay.
So that extra blood goes straight to the lungs, increased pulmonary blood flow. Then all that extra volume comes back from the lungs to the left atrium, then the left ventricle.
So the LV is getting slammed twice. Normal return plus the shunted blood.
Exactly. It has to pump out the normal amount for the body, plus all that extra shunted volume. At first, it tries to cope by stretching, dilating, volume overload adaptation. But eventually, that constant extra work just wears out the muscle.
Leading to high output heart failure.
High output heart failure. Precisely.
And clinically, you said this usually kicks in around 4 to 6 weeks, once the PVR is nice and low.
Yeah, that's the typical timing for symptoms to really emerge.
Okay.
And the signs reflect that constant effort in the wet lungs. Tachypnea, breathing fast. Retractions, you see the chest wall pulling in. Tachycardia, fast heart rate. But here's the really, really key thing to watch for. Observe the baby during feeding.
Why feeding specifically?
Because feeding is intense work for these infants. Sucking, swallowing, breathing, it's like running a marathon for them. And babies with significant VSDs will show diaphoresis, they get sweaty and pallor, they look pale just from the effort of eating.
Wow.
That leads to poor feeding, poor weight gain, failure to thrive. That feeding difficulty is a huge red flag.
Okay, so on exam, we're looking for signs of that volume overload and the resulting failure. The murmur's key, obviously, but what else?
For a moderate or large VSD, yeah, the murmur is classic. It's usually harsh, holosystolic, meaning it lasts throughout systole, and you hear it best at the left lower sternal border. the LLSB.
Got it, LSB.
And if heart failure is setting in, you listen for crackles or rales in the lungs, that's the pulmonary edema, and you feel for an enlarged liver, hepatomegaly. That's the right-sided failure backing up into the systemic veins.
Okay, this brings us to something that seems counterintuitive, the VSD paradox. The relationship between how big the hole is and how loud the murmur sounds. How can a tiny VSD be louder than a huge, life-threatening one?
Yeah, this trips people up, but it's just basic fluid dynamics. Sound, the murmur, is generated by turbulence.
Okay.
Think about water flowing. A wide-open pipe, smooth flow, not much noise. Squeeze that water through a tiny nozzle, high pressure, high velocity, lots of turbulence, lots of noise.
Right, makes sense.
So a small restrictive VSD creates a big pressure difference between the LV and RV. Blood shoots through that small hole at high speed, maximum turbulence. That gives you a loud, harsh, hollow systolic murmur.
And that baby might actually be fine.
Often, yeah.
Yeah.
Clinically asymptomatic. And those small muscular or membranous VSDs often close on their own. The loud murmur is actually, in a way, reassuring in that context.
But the huge VSD, the one causing the heart failure, the shock, that one's quiet.
Can be, yeah. Very quiet or sometimes even absent. If the VSD is really large, like the same size as the aorta's opening, there's very little pressure difference between the ventricles. They almost equalize.
So the flow is smoother, less turbulence.
Exactly. It's more laminar flow. So less turbulence, softer murmur. That quiet baby showing signs of severe heart failure. That's the one you worry about much, much more.
Okay, critical distinction. And what's the danger if a large VSD isn't closed? What's the long-term issue besides the heart failure?
The big one is Eisenmenger syndrome. Irreversible pulmonary hypertension.
How does that happen?
That constant flood of high-pressure blood into the pulmonary arteries damages the small vessels in the lungs over time. They get thick, scarred, constricted. Eventually, the pulmonary vascular resistance becomes so high, it actually exceeds the systemic resistance.
So the pressure flips.
The pressure gradient flips. The shunt reverses. Now, deoxygenated blood flows from the right ventricle across the VSD into the left ventricle and out to the body. RTL shunt.
And the patient becomes cyanotic.
They become blue. And at that point, the lung damage is usually permanent, and surgery to close the VSD is often too risky or futile. That's why we manage symptomatic VSDs aggressively with meds diuretics, maybe ACE inhibitors, nutrition, and aim for closure, either surgical or via catheter, before Eisenmenger sets in.
Okay, VSD covered. Let's move to the other classic L2R shunt, the patent ductus arteriosus, PDA. If VSD is the volume problem between the ventricles, PDA is the volume problem between the great vessels.
You got it. The ductus arteriosus is that fetal vessel connecting the aorta to the pulmonary artery, essential before birth.
But it's supposed to close.
Supposed to close within, 24 to 48 hours usually, triggered by the drop in maternal prostaglandins and the rise in oxygen. If it stays open, patent, you get a continuous L2R shunt.
Why continuous?
Because aortic pressure is always higher than pulmonary artery pressure, both during systole and diastole. So blood is constantly flowing from the aorta into the pulmonary artery.
Ah, and that continuous flow creates the classic sound.
It certainly does. That's the hallmark machine-like murmur. Continuous rumbling, often loudest around S2, the second heart sound. Usually heard best up high, under the left clavicle or left upper sternal border.
Okay, the machinery murmur. What other signs point specifically to PDA beyond that sound? You mentioned hyperdynamic circulation.
Right, because blood is constantly leaking from the aorta into the low-pressure pulmonary artery, even during diastole. The diastolic blood pressure in the body drops.
Okay.
This leads to two key findings. First, bounding pulses. Peripheral pulses feel really strong, almost like a water hammer pulse. Second, a widened pulse pressure. The difference between the systolic and diastolic blood pressure is large.
So strong pulses, wide pulse pressure, continuous murmur. Think PDA.
Definitely high on the list, especially in a preterm infant where PDAs are more common.
Okay, now we absolutely have to connect this to that management paradox you mentioned earlier. Indomethacin versus prostaglandin. This seems fundamentally important.
Hugely important. It's all about context. If you have a premature baby with a symptomatic PDA causing respiratory distress, heart failure symptoms, because of that L to R shunt flooding the lungs, you want to close the PDA.
How?
You give NSAIDs, indomethacin or ibuprofen. They work by inhibiting prostaglandin synthesis. Prostaglandins, specifically PGE1 and E2, are what keep the ductus open. Block them, the ductal muscle constricts, and hopefully it closes.
Okay, so NSAIDs to close a problematic PDA.
But, if you suspect the baby has a different underlying heart defect, where survival actually depends on the ductus staying open.
Like the ones we're about to discuss.
Exactly, those ductal-dependent lesions. Then you do the absolute opposite. You give an infusion of synthetic prostaglandin E1, PGE1,
To keep it open.
to actively keep it open. PGE1 is a potent vasodilator for the ductus. It overrides the natural closing mechanisms, knowing when to close versus when to open the ductus. Honestly, that's one of the most critical decisions in neonatal cardiology. Life or death sometimes.
Okay, perfect transition. Section 2, the ductal dependent urgencies. Let's be crystal clear on why the PDA is the lifeline here, because you said the timeline is hours, not days.
Absolutely. In these defects, the heart's normal plumbing is fundamentally broken. The PDA acts as a critical bypass. It either provides essential systemic blood flow when the left side can't, or it provides essential pulmonary blood flow or mixing when the right side can't get blood to the lungs, or circuits are parallel.
And if it closes.
Catastrophe, sudden collapse, usually happens, day 1 to day 3 or 4 of life as the natural closure process kicks in. Shock, severe cyanosis, death if not recognized and treated immediately with PGE1.
Okay, let's start with one where the PDA provides systemic flow. Coarctation of the aorta. You called it the pressure trap.
Yeah, coarctation is a narrowing like a kink in the aorta. Usually happens right around where the ductus inserts juxtadental. Now, before birth, while the PDA is wide open.
It doesn't matter as much.
Right. The lower body gets its blood supply from the right ventricle, through the pulmonary artery, across the PDA, into the descending aorta. An R to L shunt across the ductus is normal fetal circulation.
But then the PDA starts to close after birth. What happens then?
Then the descending aorta, everything below the narrowing, suddenly loses its main blood supply.
Yeah.
The left ventricle is now trying to force blood through this severe obstruction. The afterload, the resistance the LV pumps against goes through the roof.
And the heart just can't handle it.
It fails quickly, leads to cardiogenic shock. The baby becomes lethargic, feeds poorly, might look gray or ashen, sweaty, often presenting within the first week.
What's the absolute giveaway sign on exam for coarctation?
It's the pulse discrepancy. The upper body, supplied by vessels branching off before the coarctation, usually has normal, strong pulses, brachial, radial. But the lower body, supplied after the coarctation, has weak or critically absent femoral pulses. You might also feel a delay between the brachial and femoral pulse, the brachial-femoral delay. Finding a baby in shock with good arm pulses but absent leg pulses screams coarctation.
And the immediate fix is PGE1.
Immediate 4V prostaglandin E1. It reopens the ductus arteriosus. That restores the R to L shunt from the pulmonary artery to the descending aorta, effectively bypassing the obstruction.
Buys time.
Buys critical time. Stabilizes the baby, restores perfusion to the lower body, allows them to get strong enough for definitive surgical repair, usually cutting out the narrowed segment and sewing the ends back together.
You mentioned that sometimes coarctation isn't severe enough to cause that neonatal collapse. It can show up later.
Yeah, milder forms might present later in childhood or even adulthood. The body compensates. The LV works harder, leading to significant hypertension, but only in the upper extremities.
Ah, because the pressure's high before the narrowing.
Exactly. And over years, the body develops collateral blood vessels to bypass the blockage. This can lead to classic signs on chest X-ray. First, rib notching, the enlarged intercostal arteries erode the underside of the ribs. Second, the 3 sign, the shape of the aorta with the indentation and the dilated segments before and after, looks like the number 3.
Fascinating. Okay, let's touch on the extreme end of systemic ductal dependence while we're here. Hypoplastic left heart syndrome, HLHS.
Right, HLHS is really devastating. The entire left side of the heart mitral valve, left ventricle, aortic valve, ascending aorta is severely underdeveloped, basically non-functional.
So the left side can't pump blood to the body at all. How does the baby survive, even for a minute?
The right ventricle has to do everything. It pumps blood to the lungs via the pulmonary artery as usual, but it also has to supply the entire body.
How?
Oxygenated blood returning from the lungs has to cross from the left atrium to the right atrium through the PFO, mix with the deoxygenated blood there, get pumped by the RV into the pulmonary artery, and then, crucially, flow backwards across the PDA into the aorta to supply the body.
So the PDA is the only outlet to the systemic circulation.
The only one. Closure of the PDA in HLHS means immediate loss of all systemic blood flow. Total circulatory collapse. It's absolutely dependent on PGE1 from the moment of birth. And the long-term fix is a series of complex staged surgeries, the Norwood, Glenn, and Fontan procedures to replumb the circulation.
Truly incredible physiology. Okay, let's shift to the other main type of ductal dependence where the PDA is needed for pulmonary blood flow or mixing, transposition of the great arteries, TGA. This is the parallel circulation problem.
Exactly. In TGA, the plumbing is switched.
Yeah.
The aorta comes off the right ventricle and the pulmonary artery comes off the left ventricle.
So deoxygenated blood goes from the body to the RV, out the aorta, back to the body.
Correct. And oxygenated blood goes from the lungs to the LV, out the pulmonary artery, back to the lungs.
Two separate loops that don't mix. That sounds immediately fatal.
It would be, except for any small connections that allow some mixing between the two circuits. The PFO, maybe a VSD if one is present, and critically the PDA.
So survival hinges on mixing. What's the classic presentation?
These babies present fast, within the first hours of life, usually. Severe central cyanosis, they're profoundly blue and hypoxemic. But here's the weird part. They often look surprisingly comfortable.
Not gasping for air like you might expect.
Not typically, no. They might be breathing fast, tachypneic, but they aren't usually showing signs of respiratory distress like retractions or grunting. They're just blue. Because the problem isn't getting air in, it's getting oxygenated blood out to the body.
And the hyperoxia challenge confirms this. Giving them oxygen doesn't help much.
It fails miserably. You put them in 100% oxygen and their oxygen saturation barely budges. Because the oxygen is getting into the blood in the lungs just fine, but that oxygenated blood is trapped in the pulmonary circuit. It can't get to the body where it's needed.
Okay. Any specific exam or imaging clues for TGA?
The heart sounds can be tricky, but often you hear a single, loud second heart sound, S2. That's because the aorta is positioned anteriorly, right up against the chest wall, making its closing sound very prominent. Murmurs are often absent unless there's a significant VSD or PDA flow.
And the X-ray.
The chest X-ray can show the classic egg on a string sign. The heart looks like an egg lying on its side, and the superior mediastinum, the area where the great vessels are, looks narrow because the aorta and pulmonary artery are lined up front to back instead of twisting around each other normally.
Okay, so TGA is diagnosed. What's the urgent management plan? It sounds multi-step.
It is. Step 1, absolutely immediate. Start prostaglandin E1 infusion. Keep that PDA open.
For mixing.
For mixing. The PDA allows some oxygenated blood from the pulmonary artery, coming from the LV, to shunt across into the aorta, coming from the RV, improving systemic oxygenation a bit.
Is that usually enough?
Sometimes not enough, or only temporarily. If the baby remains severely cyanotic despite the PGE1, the next urgent step is a balloon atrial septostomy, the Rashkind procedure.
What does that involve?
It's done in the cath lab, bedside even sometimes. A catheter with a balloon is threaded across the PFO into the left atrium, the balloon is inflated, and then yanked back forcefully into the right atrium, tearing open the atrial septum.
Creating a big ASD.
Creating a big hole between the atria. This allows much better mixing of oxygenated blood returning to the LA with the deoxygenated blood in the RA, significantly improving systemic oxygen saturation. It's a bridge.
A bridge to definitive surgery?
Exactly. A bridge to the arterial switch operation, the ASO. That's where they surgically transect the aorta and pulmonary artery, switch them back to the crutch ventricles, and also move the coronary arteries. Ideally done within the first week or two of life.
All right, we've covered the ductal dependencies. Now let's shift into the cyanotic world more broadly, focusing on the most common cyanotic defect that often presents beyond the immediate newborn period. Tetralogy of Fallot, TOF. The name implies 4 things.
That's right. Tetralogy means 4. You need all 4 components. 1, a large ventricular septal defect, VSD. 2, an overriding aorta, meaning the aorta sits kind of above the VSD, receiving blood from both ventricles. 3, right ventricular outflow tract obstruction, or RVOT obstruction, usually pulmonary stenosis, PS, a narrowing at or below the pulmonary valve. And 4, right ventricular hypertrophy, RVH. The right ventricle muscle gets thick from pumping against that obstruction.
Okay, 4 parts. But the severity, the clinical picture, really hinges on just one of them.
Primarily, yes. It hinges on the degree of that RVOT obstruction, the pulmonary stenosis. That determines how much blood can get from the right ventricle to the lungs versus how much takes the easy way out across the VSD into the overriding aorta.
So if the pulmonary stenosis is mild,
If it's mild, resistance to flow into the lungs is relatively low. Blood might actually prefer to go L to R across the VSD or maybe just a little R to it. The baby might not be blue at rest or only slightly, sometimes called a pink tet.
but if the PS is severe,
If it's severe, the RV faces a huge amount of resistance trying to push blood into the pulmonary artery. So a lot more deoxygenated blood will shunt arterial across the VSD, mix with oxygenated blood in the aorta, and go out to the body. That causes cyanosis, especially noticeable when the baby cries or exerts themselves, increasing oxygen demand.
got it. What does the exam tell us? What's the murmur in TOF?
The key murmur in TOF is due to the pulmonary stenosis. It's a harsh systolic ejection murmur, often crescendo decrescendo, heard best at the left upper sternal border, LUSB.
LUSB, different from the VSD's LLSB.
Critical distinction. LUSB murmur points towards the RV outflow. You might also hear a single S2 sound because the pulmonary component is soft or inaudible due to the
In
stenosis.
the X-ray finding.
The RVH, that thickened right ventricle, often lifts the apex of the heart off the diaphragm, creating the classic boot-shaped heart or courant sabot appearance on chest X-ray.
Okay, now for the really dramatic part of TOF, the TET spell. These sound terrifying. What exactly happens? What triggers them?
They are terrifying. A TET spell, or hypercyanotic spell, is a sudden, acute worsening of cyanosis, often triggered by things like crying, feeding, agitation, dehydration, anything that changes the baby's hemodynamics suddenly.
What's the mechanism? Why do they suddenly get so blue?
The core mechanism is thought to be a sudden spasm, or increased contraction of the muscle just below the pulmonary valve, the infundibular muscle, part of the RVOT. This acutely worsens the RVOT obstruction.
So resistance to pulmonary blood flow skyrockets.
Instantly skyrockets. Now, the blood in the RV has two choices. Push against this now severely obstructed RVOT, or shunt easily arteval across the VSD into the aorta.
It takes the path of least resistance.
Massively increases the arterial shunt. Very little blood gets to the lungs. Tons of deoxygenated blood floods the systemic circulation. Leads to profound hypoxemia, acidosis, sometimes limpness or loss of consciousness. A true emergency.
Okay, so the life-saving trick, the thing parents are often taught, putting the baby in the knee chest position or having an older child squat. Why does that work? It seems so simple for such a serious event.
It's beautiful physiology, actually. Squatting, or pulling the knees to the chest, does one crucial thing. It kinks the femoral arteries and veins in the legs.
Okay, and that does...
That dramatically increases systemic vascular resistance, SVR. By clamping down on those big arteries, you increase the pressure in the aorta and the entire systemic circulation.
So you're making it harder for the blood to shunt arterial across the VSD.
Exactly. You've just increased the resistance of the escape route, the VSD to the aorta. Relatively speaking, pushing blood forward through the now spasmed but maybe less resistant by comparison RVOT into the lungs becomes slightly easier.
So you redirect flow back towards the lungs.
You force more blood into the pulmonary circulation, reduce the R-to-L shunt, and improve oxygenation. It's a mechanical fix. Other acute measures include calming the infant, giving oxygen, though its effect is limited, sometimes morphine to sedate and relax the spasm, or beta blockers like propranolol.
Amazing. Okay, let's weave in some critical syndromic connections now. Knowing these can sometimes clinch a diagnosis when the picture is complex.
Absolutely high yield. Let's start with the most common chromosomal abnormality, Down syndrome, trisomy 21. The cardiac link is incredibly strong.
And the most common defect is?
Complete atrioventricular septal defect, CAVSD, sometimes called AV canal defect or endocardial cushion defect.
What does that entail anatomically? What's the defect?
It results from problems with the endocardial cushions forming in the center of the heart. You end up with a hole low in the atrial septum, an ostium primum ASD, a hole high in the ventricular septum, an inlet VSD, and often instead of two separate mitral and tricuspid valves, there's a single common AV valve spanning the defect.
That sounds like a recipe for a massive shunt.
It is. Huge potential for L2R shunting at both the atrial and ventricular levels.
But like the VSD, the symptoms might not appear right away.
Correct. Similar timeline. As the PVR drops over the first 6 to 8 weeks, the L2R shunt becomes significant, leading to signs of heart failure, tachypnea, poor feeding, failure to thrive.
Any specific exam finding for CAVSD?
A very characteristic finding can be a wide and fixed split S2. The second heart sound has two components, A2 and P2, and normally the split between them varies with breathing. With the large ASD component of a CAVSD allowing constant flow, the split often remains wide and doesn't change with respiration. Fixed splitting.
Okay, Down syndrome links to CAVSD. Next up, DeGeorge syndrome. That's the 22q11.2 deletion, right? Affects pharyngeal pouch development.
Yes, specifically the third and fourth pharyngeal pouches. The mnemonic KTCH22 is super helpful.
Break it down for us.
C is for cardiac anomalies, specifically contratruncal defects problems with the outflow tracts. Think tetralogy of Fallot, truncus arteriosus, where only one great vessel leaves the heart instead of two, interrupted aortic arch. A is for abnormal facies. T is for thymic hypoplasia, leading to T-cell deficiency and immune problems. C is for cleft palate. And H is for hypocalcemia, or hypoparathyroidism, because the parathyroid glands also come from those pouches.
So if you see a baby with, say, TOF and then they have seizures due to low calcium,
You should be strongly suspecting DiGeorge syndrome. That combination is highly suggestive.
Got it. Lastly, Turner syndrome. Monosomy X, 45X. What are the key cardiac risks there?
Two major associations stand out. First, bicuspid aortic valve. Having two aortic valve leaflets instead of three. This can lead to stenosis or regurgitation later in life.
And the second?
Second, and often more immediately relevant in terms of severity, is coarctation of the aorta. We already discussed coarc, but its association with Turner syndrome is very strong.
Okay. But beyond the valve issue and the coarctation itself, is there a bigger long-term danger for the aorta in Turner syndrome?
Yes, definitely. There's an increased risk of aortic dilation and subsequent aortic dissection or rupture later in life. This is related to an intrinsic weakness in the aortic wall, sometimes called cystic medial necrosis, compounded by the hypertension often associated with the bicuspid valve or coarctation, requires lifelong monitoring of aortic size.
Okay, we've covered the main structural defects. But sometimes the problem isn't the structure itself, but how the circulation adapts or fails to adapt after birth. Let's talk about mimics and adaptations. First, persistent pulmonary hypertension of the newborn, PPHN.
Right. PPHN is essentially a failure of that normal transition we talked about at the beginning.
Yeah.
For some reason, maybe stress during birth, meconium aspiration, infection, the baby's pulmonary blood vessels fail to relax properly after birth.
So the PVR stays high, like in the fetus.
Exactly. The pulmonary vascular resistance remains abnormally elevated. Now, the right ventricle is pumping against this super high resistance. Just like in fetal life, blood finds it easier to take the path of least resistance.
Shunting R to L.
Shunting R to L across the foramen oval, PFO, and importantly across the patent ductus arteriosus, PDA, bypassing the high-resistance lungs entirely. This leads to significant hypoxemia.
Okay, so a blue baby, but the heart structure is actually normal. How do we tell PPHN apart from something like TGA or severe TOF?
The key clue is often differential cyanosis or differential saturation, but with normal pulses.
Explain differential saturation.
The R to L shunt across the PDA occurs after the arteries branching off to the right arm have left the aorta. So blood going to the right arm, preductal, is relatively better oxygenated than the blood going to the lower body, postductal, which has received that shunted deoxygenated blood from the PDA.
So you check O2 saturation in the right hand and compare it to the foot.
Exactly. If the right hand saturation preductal is significantly higher, say by 5–10% or more, than the foot saturation, postductal, that strongly suggests a R to L shunt at the ductal level, characteristic of PPHN. Critically, unlike in severe coarctation, the femoral pulses should be present and strong because there's no aortic obstruction.
Got it. Pre versus postductal sats differ, but pulses are okay. And the management is totally different from structural heart disease.
Completely different. The goal is to relax those constricted pulmonary arteries and lower the PVR. Mainstay therapy is often supportive care with oxygen and ventilation, but the specific treatment is inhaled nitric oxide, INO.
How does that work?
Nitric oxide is a potent natural vasodilator. When you inhale it, it goes directly to the alveoli, diffuses into the smooth muscle of the pulmonary arterioles, and makes them relax.
Lowering PVR.
Selectively lowering PVR right where you need it, without causing widespread systemic vasodilation and hypotension. This encourages blood to flow into the lungs instead of shunting past them.
And crucially, you would not want to give indomethacin here.
Absolutely contraindicated. Closing the PDA with NSAIDs in PPHN would eliminate one of the R to L shunt pathways, but wouldn't fix the high PDR.
Yeah.
It could worsen right heart strain and potentially worsen the situation. Need to lower the PVR first.
Okay. Now, for a much more common and thankfully benign mimic, acrocyanosis, this causes a lot of parental anxiety.
It really does.
Yeah.
But it's important to distinguish it from true central cyanosis. Acrocyanosis is that bluish discoloration you see only in the extremities, hands and feet, and sometimes around the mouth, the circumoral area.
But not everywhere.
Critically, not the mucous membranes. The tongue, the inside of the lips, the nail beds, those should remain pink. It's purely a peripheral phenomenon.
What causes it?
It's just due to sluggish peripheral circulation and vasomotor instability in the newborn. The tiny blood vessels in the hands and feet constrict a bit in response to the cooler environment outside the womb. It's temporary.
And the key difference from serious cyanosis is?
Systemic oxygen saturation is normal. The baby is otherwise pink, centrally, vigorous, breathing fine, feeding well. Pulse oximetry reading will be normal.
So management is just reassurance.
Reassurance and routine care. Keep the baby warm. Usually resolves on its own within a day or two.
Yeah.
Still needs the standard 24-hour critical congenital heart disease screen with pulse oximetry, but
Yeah.
it's not an emergency like central cyanosis.
Good distinction.
Yeah.
Okay, let's briefly revisit the VSD, but in a totally different context, acquired VSD in adults. Our sources mention this as a post-MI complication.
Yes, ventricular septal rupture, a truly catastrophic mechanical complication of a heart attack. It doesn't happen immediately, typically occurs 3 to 5 days after the MI.
Why the delay?
That's the time it takes for the heart muscle damaged by the infarct, particularly in the septum, to become necrotic, soften, and eventually tear open under the pressure difference between the ventricles.
So suddenly, a large hole appears.
A large hole appears acutely, leads to a massive L2R shunt, just like a congenital VSD, but happening suddenly in an adult heart not prepared for it.
And the patient crashes.
Immediate cardiogenic shock, acute pulmonary edema. The clinical hallmark, tying back to our earlier discussion, is the sudden appearance of a new, loud, harsh, holostolic murmur, often with a palpable thrill right at the left sternal border. Classic VSD sound, but in the context of a recent MI and sudden decompensation, requires emergent surgical repair.
Wow. Okay, finally, let's apply these concepts of cardiac adaptation to a different challenge. Distinguishing a healthy athlete's heart from a dangerous condition, hypertrophic cardiomyopathy, HCM.
Yeah, this is really important, especially in screening young athletes, because HCM is a major cause of sudden cardiac death. Athlete's heart involves physiologic remodeling the heart, adapting healthily to increased demands. HCM is pathologic.
What does the healthy athlete's heart look like? How does it adapt?
Endurance training imposes both volume load, more blood returning, and some pressure load. The heart adapts primarily through eccentric hypertrophy. The left ventricular cavity size increases slightly to handle the extra volume. The walls thicken too, but uniformly and symmetrically.
How thick is too thick?
Generally, in physiologic athletes' heart, wall thickness stays below about 15 millimeters. Diastolic function, the heart's ability to relax and fill, remains normal or even enhanced. The left atrium usually stays normal size. And resting bradycardia, a slow heart rate, is common due to increased vagal tone. It's a sign of efficiency.
Okay, so bigger cavity, symmetric thickening, good function. How does HCM differ?
HCM is characterized by asymmetric hypertrophy. Most commonly, the interventricular septum becomes disproportionately thick, often significantly exceeding 15 millimeter.
And that causes problems.
Big problems. That thick septum can bulge into the left ventricular outflow tract, obstructing blood flow out of the heart, LVOT obstruction. The overall LV cavity size might actually be normal or even decreased. Crucially, diastolic function is usually impaired. The thick, stiff muscle doesn't relax well, and the left atrium often becomes enlarged because of the high filling pressures. This disordered pathological thickening is what sets it apart and carries the risk.
So asymmetry, marked thickness, 15 millimeters, small cavity, diastolic dysfunction, large LA, those point towards pathology, towards
Oh,
HCM.
exactly. Distinguishing these two is critical. Echocardiography is key. #tag outro.
We have covered an immense amount of critical information today, from those first few minutes of life right through to adaptations in adulthood. It's a lot to take in.
It really is.
If there are just a couple of absolutely crucial takeaways, for me, it's that time sensitivity with the ductal-dependent lesions, neonate and shock are profoundly blue, PG1 first, ask questions later almost. It buys that essential time.
Absolutely. And remembering the location of those murmurs. LLSB, think VSD, volume shunt down low. LUSB, think TOF, outflow obstruction up high. Connecting the sound to the likely anatomy. And the timing, TGA hits in hours, couric in days. The big volume shunts like VSD, CAVSD, PDA take weeks to show failure typically.
And that TET spell mechanism, squatting isn't magic, it's physics. You're changing the SVR versus the PVR balance. Just brilliant applied physiology.
It really illustrates how interconnected everything is and how much hinges on understanding whether that tiny ductus arteriosus needs to be open or closed. That single decision point.
We spent a lot of time today talking about the incredible interventions, PG1, surgery like the arterial switch, fixing tetralogy that allowed these kids to survive conditions that were uniformly fatal not that long ago.
The progress has been phenomenal.
It really has.
Yeah.
Which leads us to our final provocative thought for you, the listener. Given this success, we now have a growing population of young adults who survived complex congenital heart disease. We focused on fixing the heart, but what comes next? What are the non-cardiac challenges, the potential developmental hurdles, the psychological impact, the social integration questions that this generation faces? How do we ensure not just survival, but a truly full quality of life long-term?
That's a vital question. The next frontier in care for these patients, really.
Something to think about. We'll catch you on the next deep dive.